You're tuning into the Active Mom Podcast with physical therapist Dr. Carrie Pagliano, a real mom's guide to all things postpartum return to workouts after baby. If you're a postpartum mom, coach, trainer, or physical therapist looking for answers on how to get back to running, CrossFit, yoga, Pilates, HIIT, you name it, without the fear of pelvic floor issues or doing something wrong, this is the podcast for you. Let's start the show. All right, so we have an interesting next guest on the show, Todd Davenport. He's a professor and chair in the Department of Physical Therapy at University of the Pacific in Stockton, California. I cannot remember how long or what context that we met or have known each other, but he's just a smart guy that talks about smart things, and one of them being relevant into a lot of the stuff that I do is navigating chronic fatigue. And those of you that practice in pelvic health and work in chronic pelvic pain, working with women, like it's a dumpster fire of a diagnosis. And so one of the many reasons I follow him, but I thought it would be fun to have him come on and talk about some of the work that he's doing and some of the smart things that he understands about chronic fatigue and other things related to it. So Todd Davenport, welcome to the Active Mom Podcast.
Thank you. I really appreciate being on, and hopefully I can earn that kind introduction. Wow, that's kind of
you are one of very few men that have been on the show. Another one I was listing off to you before we hopped on. We had Rich Willie, Jay Deschieri, Chris Johnson. We also had James Clear.
Awesome.
Who did Atomic Habits. He went to college with like Shefali Christopher or something like that. So,
That's cool.
So welcome to the club. I don't have a jacket for you or anything like that.
That's okay. Those are some big shoes to fill. That's
right?
Fantastic. Yeah, good stuff.
All right, so let's dive into kind of some of the stuff. You refer to it as ME/CFS. Unpack what that is, what that presentation is. So those of us that are providers, we can kind of connect to what you're talking about. Those that are moms can kind of be like, hey, that this might be something I want to listen to.
Yeah, thanks. So I just a real quick piece of background that might interest your listeners about me. I actually got my start in a pelvic pain practice.
Oh, nice.
Down in LA. And that was my first job out of my residency program, my first big boy job. I was adulting. And I had a chance to sort of work. We had physical therapists who worked with kind of doing the internal evaluation and work. And I was doing most of the extra pelvic evaluation and, sort of therapeutic exercise prescription and different things. So I got to know pelvic health practice up close. Yep. And just really realized that, as you've mentioned, pelvic health practices are just kind of an intersection of people who have many different types of health conditions. And so it's not just pelvic pain and dysfunction, but it's also all the things that go along with it. So chronic pain, chronic fatigue, and different things. And so honestly, this ME/CFS thing I was probably seeing before I knew what I was seeing. And it tends to be a thing that blends into plain sight. And so I'll talk a little bit more about what I mean about that, but just ME/CFS stands for myalgic encephalomyelitis / chronic fatigue syndrome. So chronic fatigue syndrome is sort of the colloquial way that we put it. And I would say it's probably the worst description in the world, because who isn't tired, right? Like, who isn't tired? So early on in my career, when I started looking at this 15 years ago, people would say, what do you study? As like a professor, like what's your science and stuff? And I'd be like, yeah, I'm studying this thing called chronic fatigue syndrome, thinking I'm doing people a favor by using the non-Latin term. And they'll go, oh, thank you. Sometimes I just get so tired in the afternoon that I need coffee in the afternoon. I'm like, no, that's not that. Not that at all. And so I started using this condition's full Christian name of myalgic encephalomyelitis, because it's much more descriptive. It really talks about a syndrome, an illness, a disease process that's distinct from almost anything else that I'd ever heard of. And myalgic encephalomyelitis is or ME, as I'll call it, is a multi constellation of symptoms and signs that really come down to be associated with the body's inability to adapt to some kind of load. And that load might be going for a run or exercising, hit workout, something like that. Or it could be reading a computer screen or like doing bills. Or it could be something in the environment like strong sense and chemical sensitivity and so forth. So these triggers, I'm a physical therapist and exercise scientist, and so my whole world is movement. But there's a lot more than just exercise that triggers this condition. And what these triggers cause, just normal daily activities. It doesn't have to be anything exotic, just normal stuff, will cause debilitating fatigue. And fatigue is just not the word for it. I mean, I've worked with marathoners who have ME, and they will say that the fatigue following a marathon does not hold a candle to the fatigue
Wow.
associated with ME. And if you can imagine that, I can't imagine that.
Yeah.
It's after a marathon, you can't even stand.
Right.
Um, but it's not just fatigue. It's not just this crushing, debilitating fatigue. It's also like cognitive dysfunction. Like you can't think as clearly and as well. I hear people talking about it like I'm thinking through Jello. Can't think. I'm slower processing. Can't process conversations. People trying to follow this podcast would already be having a hard time because I'm speaking kind of
Mm.
quickly. I make the conscious choice to modify my cadence to take out inflection and to slow myself down, like the most boring NPR voice you've ever heard, in order to like accommodate the auditory processing issue that goes with cognitive dysfunction. Some
Mhm.
people call this brain fog, but that's kind of a cutesy thing that makes it sound almost like almost funny, but there's nothing funny about it. But also sleep disturbance, not sleeping as deeply, as much, or like as well.
Mhm.
Immune dysfunction. Sometimes you have issues of people feeling like they've got viral reactivation in response to a trigger, sore throat, swollen glands, feeling crummy. Um, you shouldn't have that after a run. That's not normal.
Yeah.
Um, in addition to chronic pain, and so forth. So again, you've got this whole host of different signs and symptoms, and the experience of these signs and symptoms is deeply individual. So some people will have more debilitating fatigue, some people will have more cognitive dysfunction. Almost everyone doesn't sleep well, so that's just kind of a commonality. Some people will have more widespread body pains, joint pains. Um, and so this comes on after triggers. There's usually like an onset delay.
Mhm.
The onset delay commonly is 1 to 3 days after a trigger. And what that does is it makes it really difficult to know what was it
Mm.
that set things off. As clinicians, we're always trying to think about cause and effect relationships, but trying to establish a cause and effect relationship when there's a delay built into the system
Right.
is really hard. So I spend a lot of time with my patients with ME trying to help develop these cause and effect relationships by doing journaling and different things.
Mhm.
And there's a wide variation in recovery time from these symptoms. Um, that ranges anywhere from 3 days to 2 weeks, or sometimes these symptoms don't come and go. Sometimes they just come and stay. And so there's
Yeah.
no up and down. There's just down. Um, and so that's sort of like the general presentation of myalgic encephalomyelitis, and kind of how somebody has it. Um,
As
so
you're kind of describing some of that stuff, the other thing, because it's totally in my brain right now, is so much of that too also sounds like menopause. So how do you differentially diagnose?
yeah,
And I think that's where women, and you kind of mentioned something briefly before we got on about how there's a lot of crossover with women. Like, how do women figure out, is this menopause? Is this chronic fatigue? Am I gaslighting myself? Is my provider gaslighting me? Like, whoa, what do we do?
yeah. So I think the key differential diagnosis, Carrie, is the presence of that constellation of symptoms and signs associated with the coming and going,
Mm,
taking a long time to resolve, and resulting in a progressive loss of ability to do your daily activities.
okay.
Um, differentiates ME from other conditions clinically. There's unfortunately no approved test
Isn't that
for
nice?
ME. There's no blood test, right? That would be easy.
Right?
And there are a number of studies that point to what's going wrong in the body, but there's just no approved test
Mhm.
to pull all this together. So we don't have that luxury. So most of these, are most of these cases are identified clinically based on some of the points that I brought up earlier.
With the patients that you see with this, how are they entering the medical system? Are they, obviously they're not coming straight to you because I'm sure they're not getting diagnosed right away, but like what's that pathway and chronology and how long does it take to get to somebody who can actually diagnose accurately?
Yeah, it's a good point. I mean, so the existing studies suggest that maybe there's somewhere on the order of 7 years between the onset and diagnosis. So
Yeah.
people are pretty sick for a long time. They usually are given pretty awful advice in the short term. To try and they tend to get lumped into diagnostic buckets and services where they don't really belong. And so it makes identifying this a little bit of a challenge. Um, as for sort of what as for the kind of the whole piece about how to identify it, again, it really kind of comes back to what is the response to exertion?
Mhm.
Are there symptoms and signs that we would not ordinarily expect in response to a given level of exertion? Like, you go for a run, I do not expect you to not be able to do your bills when you get home, you know?
Right.
Like,
That's fair.
you go for a run, I don't expect for you to have widespread body pain within 2 days.
Right.
Um, if you go for a run, I don't expect you to need to be in bed for a week.
Yeah.
But commonly we see this where, particularly women, speaking to your audience, will they live for their daily run, so they run and they feel crummy, and maybe they have to deal with family commitments and work. It's just societal expectation, it's just kind of how it
Yeah.
rolls,
Yep.
unfortunately, and so you just don't have it. You have a decreasing amount of time and energy, not time but energy for other things. So people may be just trying to budget enough energy to get by. And
Mm.
that's the gaslighting,
Yeah.
right? Like, yeah, I just feel I'm a little out of it, but I'll bounce back, but there's no bounce.
Right.
Um, that's the part that to really watch for. And that's why people are really sick by the time they get to me.
Mm.
They've been sick usually for a few years. They've really tried hard to do the things they thought were good for them because, you know, we know running is good for you. We know exercise is good for you. So people are going to try and do that. If you're tired, hey, we're going to increase my PEP by exercising. And they may have been told by a
Right.
healthcare practitioner, hey, you got to exercise. Um, but that
Yep.
just turns out to make things worse. But
Mm.
in the clinic, in an average orthopedic clinic, I might see people with diagnoses like fibromyalgia that
Mhm.
turn out to have ME, persistent pelvic pain who turn out to have ME, migraines, headaches. Um, what are some of the others? Temporomandibular joint disorder. Somebody was
Mhm.
referred to for like this one little thing in their jaw, but on further questioning, there was like a whole widespread body thing happening. So,
Yeah.
the average, I think, outpatient clinician, there is no diagnosis that necessarily excludes a person from potentially having ME. So, screening
Right.
for post-exertional malaise, or its full name, post-exertional neuroimmune exhaustion, becomes really important.
Yeah. No, I spent much more of my earlier career working in chronic pelvic pain than I do now, and I just feel like a week didn't go by without having that patient that I mean, I remember my first couple years out and they're like, "Oh, they're a malingerer." Like chronic pain was just this whole dumpster fire. And looking back now, again, like I think we just see it more clearly as, yeah, these things tend to run together. Yes, it's a dumpster fire, but it's for us to kind of tease through and figure out and validate and whatnot. Um, so if somebody does finally get to you, where do you even start? Because again, there might be multiple diagnoses, they've been seeing multiple providers, it's been years. Like, how do you tease that out and get them so that there is a clear path forward?
I tend to do a lot of listening. I ask people to tell me their story because, guess what? They may have seen tens of healthcare providers,
Yeah.
100 healthcare providers, but no one's actually ever listened to the whole thing all the way through.
Yeah.
So my first couple of sessions just involve listening. And I'm listening for the kind of key characteristics of post-exertional malaise, and I may follow up on some of those just to kind of ask about behavior patterns and how long does it take for things to get worse and better. And they're basic clinical questions. I mean, these are things that I teach my students and residents and fellows to
Hmm.
ask and follow up on. So there's nothing exotic here.
Yep.
It's just an issue of how you put things together. It's really kind of the clinical reasoning underneath.
Right.
Um, and again, I'm looking for that pattern. I'm looking for that post-exertional pattern of gets worse, unusual symptoms, usually gets worse within a couple of days. It's not like delayed onset muscle soreness that's like 24 to 48 hours, it's stiff and
Hmm.
it's gone. But it may take a week or 2 weeks or just not recovering, from some kind of an exertion.
Hmm.
And again, highlighting those unusual symptoms and signs. Um, and then the way forward really has to do with what we think is underlying ME. Um, and what we think is underlying ME in part is, this issue of um, the inability of the body to produce and consume energy in a normal way. Um, and what I mean by that is one of the first things that we clinicians learn is kind of how we physical therapists, especially, we learn is the biochemical process of how the body creates energy molecules, which I've now put most of your most of your list going that far. But it's the first thing we learn, and obviously it's very in depth. It's affectionately referred to as the Krebs cycle, but we also call it oxidative phosphorylation by its full scientific name. And it's the first thing we try and forget because it's kind of traumatic for us. Like there's a lot of steps to remember.
I'm shaking here now.
I
Yeah.
know, like sorry, Carrie, like I'm sorry to your listeners who are clinicians. Everyone's just kind of like, okay, am I going to stick with this or is this going to go off now? Um, but you know, what we find is that Krebs cycle, that body's ability to manufacture energy using oxygen, is not normal.
Mm.
And in fact, because it's not normal, an exertion of some kind may use it up. So you can't use it again until it replenishes itself. And it takes a much longer time to replenish itself because the body does not respond normally. And particularly in response to physical exercise, we know that this process involving oxygen, we would call it aerobic metabolism, like aerobic exercise. That's the energy system you're training on a long run and so forth. Anything over about 90 seconds is long. um, but that metabolic process doesn't work.
Mm.
And so because it doesn't work, we have to keep people away from using it. And so the initial treatment that we use is what we might call pacing. It is a less is more type of an approach, whereas exercise is kind of a more is more type of an approach. We're trying to
Mhm.
overload the body. Here we're doing something, as Monty Python would say, completely different,
Mm.
where we're trying to make sure that people underload so that they can ideally replenish their ability to make energy molecules using oxygen again. So that's kind of
Now,
the first piece.
so with pacing is the idea, it's almost like I don't think graded exposure is what I'm going for, but you kind of get the idea. It's like we're undershooting, but that ceiling ideally is continuing to move up. Is that kind of what we're trying to do?
That's the ideal situation, is that
Okay.
a person's capacity improves,
Yeah.
pacing yourself better. I think people with ME related to long COVID are experiencing that a little bit more than my patients with ME who've been sick for years and we just didn't know as much as and able to implement as much now. There's a lot of advice kind of out there about what to do if you have COVID, and potentially long COVID. And one of the favorite social media hashtags that was created by ME Action, and it was kind of perpetuated by a lot of groups, including my group Long COVID Physio, is hashtag Stop Rest Pace. So we're not trying to run the virus off. We're not trying to sweat it out.
Mm.
You know, we're not trying to overexert during the acute phase, trying to rest as much as we can. And then if you do develop long COVID, again, exercise not being the answer. Stop, rest, pace. Making sure that you are breaking up your daily activities into more manageable chunks, prioritizing daily activities, to make sure that you're not overexerting, and potentially making your symptoms worse.
Okay. Let's back up a step. You kind of hopped right over into long COVID. What do we know about kind of the relationship of ME and because and long COVID? Because I also think people have this idea of what long COVID is like you can't do anything. You're like and I think there's varying degrees of post-viral stuff. Where is there a connection between these two? Because I think probably there are more providers seeing this and not realizing that this is what they're seeing, and also people experiencing this but not realizing this is what they're seeing because they're not making that connection between the second COVID infection that they've had this year and what's going on now. So if you could kind of summarize that, that would be great.
Yeah, it's a good question, and happy to do it. So the National Academies of Science, Engineering, and Medicine just came out with a kind of a unifying definition of long COVID. And so I'd invite. We'll put the link in the show notes so that way the clinicians can take a look at that. And there's a nice explainer for folks who don't have a medical background. So we'll make sure that we include that as
Awesome.
well. Layperson summary. But long COVID is a lot of things. It is prolonged signs, symptoms, and disability following a confirmed or suspected SARS-CoV-2 infection. Suspected because we're not testing anymore, a lot of us. So, if it walks like a duck and it talks like a duck, it must be a duck as far as the SARS-CoV-2 infection is concerned. And it's defined as symptoms and signs that extend 3 months beyond, for at least 3 months. And so the symptoms and signs may run right through the acute phase. So that acute phase, people get sick and they don't get better,
Mhm.
or people may get sick, they improve, and then they get worse again.
Mm.
So that there's this period of improvement that they get worse again. And I think long COVID is generally acknowledged to be an umbrella term involving end organ damage. Some people get lung damage. They get damage to the interior of their blood vessels related to COVID. So that's part of long COVID. They have circulatory impairments, myocarditis, infection of the heart. There's also acknowledged to be post-viral deconditioning, like you're down for a bit and you haven't been doing your normal exercise routine, your normal activities. And so when you get up and going again, it's a little hard to get going, but your body adapts and responds and eventually can kind of get up and moving again.
Mhm.
And then we have a subset that meets the case definition criteria for ME.
Mhm.
And so they have post-exertional neuroimmune exhaustion. And the thing that's notable about this subset is this subset becomes increasingly common as time goes on. So
Mm.
the longer you don't get better, the more likely you are to show post-exertional malaise or post-exertional neuroimmune exhaustion,
Mhm.
which is consistent with ME. So
Mm.
that ME subset becomes more frequent over time. And I agree with you, Carrie. I think you hit the nail on the head that as I mentioned earlier, it's a disease that's hiding in plain sight. People with this disease don't live normal lives, but in very mild forms, they're able to kind of get by
Yeah.
with strategies and lots of social support. But as that functional baseline decreases, then it becomes a lot harder to kind of hide it.
Yeah. Is there, considering kind of we'll just talk about the average American has had probably at least 2 or 3 infections by this point. Um, is there any correlation between or anything that we know about severity of acute infection or frequency of infection and likelihood of being in this subset that might kind of be classified more as ME?
Yeah, I mean, there's a brand new study out on the development of long COVID, kind of as an umbrella, and I haven't had a chance to read it through carefully yet. But the cumulative the risk with a cumulative infection. So with as your infections increase, your risk for developing long COVID also increases.
Mhm.
There's some question about whether subsequent infections confer more risk than the first one, and I
Mhm.
think studies disagree on that right now. So
Okay.
some studies say that your first one is confers the most risk, and subsequent ones maybe confer a little bit less, but still confer risk.
Yeah.
What we can say is that cases of long COVID tend to increase with more infections.
Gotcha. It's really interesting. I've seen just anecdotally, and I don't know if it's just timing of this most recent surge over the summer, going into marathon season,
Mhm.
far more people being vocal about, I'm, 15, I'm supposed to run 15 or I'm supposed to run 18 today. I just can't. This is not good. And what's great, number one, is that people are sharing these stories. But what's also really sad is they're going to like respiratory doctors and they're putting them on asthma medication or
Mhm.
allergy medication or treating it like that sort of basic respiratory thing.
Yep.
And, people are trying to do what they're told and be hopeful. And these medications aren't, helping their symptoms. I would surmise because it's not targeting the problem or recognizing the problem.
Right.
Um, if I'm one of those people that's kind of my scenario, like where do you even start?
Um, I mean, it's a great question. I think the first place to start is to access high quality information. Um,
Yeah.
yeah, right. A lot of there's a lot of there's a lot of voodoo out there, and and kind of weirdness. And
That's
I'm
why you're here,
generally
Todd.
I'm good with voodoo and weirdness. I'm all for that. Like, let's have crystals and let's do some of that stuff. But I think what we need is some science here,
Yeah.
in the way of just trying to kind of nail down good advice. And so there are great tools, some tools that are coming out through the Sick Times, which is a kind of an investigative journalism platform created by two experienced investigative journalists, one of whom lives with long COVID.
Mm,
Some interesting and helpful materials there. Our organization, Long COVID Physio, has some brief animated lectures that videos that are helpful that cover some of the key topics of post exertional malaise or post exertional neuroimmune exhaustion and exercise and so forth. ME Action is another. So we can certainly post links in the show notes
yeah.
to all of these things. But I think just kind of reading about this helps to set the stage for having an informed discussion with your healthcare practitioner,
Hmm.
who may not know anything about this and
Yeah.
may be in position to need to learn. And so the second step, I think, is get in front of a practitioner who will listen to you. So,
Yeah.
and I'm sort of encouraging everyone, who's a clinician listening to this podcast to be that clinician for somebody
Yeah.
who will sit down and take the time to listen and help put the pieces together. Because that we are finding that with increasing productivity pressures, that's harder to do now is to listen and listen well.
Yeah. No, and
Um,
and and those of us again in this space, I think, especially those of us that work in pelvic space, but then also those of us who are in kind of the active person space working with marathoners and stuff like that too. Like I think it's one thing when you're telling us the story because we get it, but also, I mean, I've seen a couple people now on social that they'll go to their provider and they're saying, "I'm having trouble catching my breath at, mile 15 out of 18." And the provider's like, oh, but you're still running that far. You're fine. You'll just get over it. Like,
Yeah,
I think to have acknowledgement, and again, it's gaslighting again.
it is.
If you've run a marathon before, you shouldn't be doing that later on. But for somebody to judge you and you like, I'm still not doing what I should be doing right now. I'm not feeling the way that I should be feeling. But it's hard to find people that kind of acknowledge that may not have that personal experience in it.
Yeah, it's you raise a really good point there, and because it's all relative. So
Mhm.
you may have your 11 o'clock patient who you're trying to get to exercise more, and then you've got your patient at 11:20 who maybe has developed the early stages of long COVID, but they're still able to do 15 miles, and so you're
Right.
like, that's great, that's above the exercise recommended exercise guidelines. Keep living your life, and
Yeah.
it's deeply unfulfilling as an active person to have the basic rules applied to you, because it does feel like gaslighting.
Yeah.
And I would say that active folks tend to notice some of these activity limitations fairly quickly, because when you're
Mhm.
running 15 to 18 miles for a training session or more, you're going to notice subtle changes
Mhm.
quicker, and maybe be in position to do something constructive about it, but you have to be guided that way first as
Yeah.
well.
Is there, because again, if you don't have somebody telling you what to do, you're just gonna kind of keep going until the wheels fall off. Like, do we know yet if it's detrimental to keep pushing, to keep training or try and get to that start line? Or do we know enough to be like, hey, you know what? Pause here, get yourself together, and that's going to mean that you're going to continue to have longevity in this sport. Do we know enough yet?
Yeah, I mean, I think we do know enough. Some from work that we've done in cardiopulmonary exercise testing, to say that the body does not respond normally to one bout of vigorous exercise. And
Mhm.
if it doesn't respond to one bout of vigorous exercise, and granted, the average cardiopulmonary exercise test lasts 8 minutes, 12 minutes. So we're not even
Mhm.
talking about a
Right.
15 to 18 mile training session. That's different. Um, But if it doesn't respond once, we can't expect it to respond to chronic loading, where
Mhm.
you're trying to push it. And so yeah, if you notice unusual symptoms and signs, the first thing to do is to listen to yourself, and
Mm.
realize that this is not something to push through. Because active people, athletes, we gaslight ourselves all the time.
Oh, yeah.
Part of how it is that we get by. Right?
Yes.
It's
That's how mom
almost done. Yeah,
bye.
you're halfway done and you're saying it's almost done. Well, mathematically, it doesn't make any sense.
Yeah.
So that hill is shorter than I think it is. Okay, well, no, it's not. It is what
Yeah.
it is, but
Yeah.
we're gonna try and think our way through this. And so I would encourage people, who notice unusual symptoms and signs to listen to their bodies.
Yeah.
And that you're worth that you're worth that your training is worth that. And the hope is, if you can catch it early and
Mm.
do something meaningful about it, that there might still be the ability to restore that flexibility into the system to be able to respond.
Yeah.
But that's always in doubt until you get in the middle of trying to help somebody with this.
Right. Well, and the couple of conversations that I've had in DMs with people that have been sharing their stories, I've reached out to them, and because they're like, hey, I'm just sharing my experience. Is anybody else experiencing this? And I'll ask them, I said, how much feedback are you getting? And this one provider, she's a PT I was talking to, she's training for a marathon. And she's like, I've literally gotten hundreds of DMs saying, yeah, that was my experience too. So literally the first step was, I'm putting this out there because I don't know if I'm crazy or this is a normal thing. She's gotten
Mhm.
validation to be like, yeah, this is a thing. She's trying to go a very basic medical route, which has not given results. And so in the meantime, she's still kind of moving forward, but there there really hasn't been a clear like go see this person next. So if you're listening to this and you're resonating with it, or if you're a provider and you're working with somebody and this is kind of what you're hearing, where is next?
Mhm. Mhm. Um, Next depends on where you live, right? And it
Isn't
right?
always.
So if you're close to a long COVID clinic, then you have a shot at attending one. But the long COVID clinics ME clinics that have sort of come online, many of them are closing. Those responsibilities are sort of being punted or redistributed to other kind of healthcare practitioners. And so what we have, much like most of healthcare in the United States, is this very decentralized system where, the quality of care is very ununiform.
Mm-hmm.
Tends to be worse if you live nearer to, farmland, than if you live nearer to people
Yep.
in rural areas, for example, than in cities. If you don't live near a big academic medical center, healthcare tends to be a little worse than, or a little more fragmented. So it's really on us healthcare providers to do better.
Yeah.
So obviously, all the continuing education we can take, all of the kind of linking together and learning from each other we can do.
Mm-hmm.
All of the sort of organizational pieces that we might be able to pull together nearby us, because if you can imagine the signs and symptoms of ME associated with long COVID, they involve multiple disciplines that need
Yeah.
people are gonna need a lot of help. So multidisciplinary teams are what's needed, and so that coordination is critical.
Yeah.
Um, so right now it's a long wait for the few services that are available, or you hope that you stumble upon somebody who's heard of it,
Yeah.
or you have a practitioner who can listen to you, knows how to listen and listen well, and is willing to work with you and learn,
Yeah.
which sadly is not always the case.
Yeah. No, I feel like there's so many barriers even to get to that point because even just stereotypically thinking in my particular niche in PT, chronic fatigue, it very much like you said earlier, those fibromyalgia patients with fibromyalgia and multiple diagnoses and chronic pain and all that stuff. That's a very different and even long COVID, all those things are in a very kind of non-active stereotype, which is completely the opposite of what we were just talking about with these marathoners. And so,
Mhm.
even acknowledgement that these two things are under the same umbrella, I think it's a really hard leap for people to make. And of course, all the political, chaos surrounding just acknowledgement of COVID and long COVID and that sort of thing aside. But like,
Mhm.
let's assume that we've made the leap and everybody's kind of come along with us. They've made the leap. Um, as a provider myself, like talking about pacing, things like that, what other kind of general resources? We had Jessica Drummond on, I told you a couple weeks ago, and she's much more on kind of the holistic side of things and
Mhm.
talking enzymes and this and that. Like, what are some other really nice vetted directions besides pacing that we can take a look at?
So there are very few. There's no FDA approved treatment. Just as there's no test, there's no FDA approved
Right.
treatment for any of this. And so the treatment tends to be what we would call supportive in terms of aligning to with the person's symptoms and signs to alleviate them. Um, and so there's a whole host of different types of treatments that a person can do. Um, I think the first line is to identify whether there's another diagnosable condition that goes along with ME, because
Mm,
there are some concomitant conditions that just kind of go together. And so we've talked about fibromyalgia already, which is a commonly diagnosed. Um, a lot of diagnostic overlap with ME. Um, there's also dysautonomia, which
mhm.
essentially is a heart rate dysfunction that may be related. Your body doesn't your heart rate does not change properly with your changes in your body's position or movements. And there are certain types of pharmacological treatments for that, non-pharmacological treatments for dysautonomia. There's also what's called mast cell activation syndrome. Mast cells are are immune system cells, and if you've ever sat in the grass and got a rash, that red itchy rash, then you've met your mast cells. That's what they do. So they basically create this kind of inflammatory process, which is fine if you're sitting in the grass, but if you're getting mast cell activation associated with eating food or some kind of environmental stimulus, then that's more problematic. So
Mm-hmm.
identifying mast cell activation becomes important. And then there are some folks who have this for maybe long enough that they start to develop hyperflexible joints.
Mm-hmm.
So joint hypermobility is another thing that we would identify and try and address alongside all this. So the first is to try and find out if there's a diagnosable condition, and then the treatments associated with that,
Yeah.
along with energy management strategies and so forth, are probably where most of the science is headed. Although there's a lot in the way of nutraceutical supplementation that people are playing with. That I would consider that more patient-derived and practice-derived knowledge at
Mm-hmm.
this point than maybe strictly scientific, and there's nothing
Yeah.
wrong with that. It's just your mileage may vary.
Gotcha. Yeah, I will say the one good thing that's come out of this, is I've treated clients with POTS over the years because lots of times they come in, with urgency frequency from a
Sure.
bladder perspective,
Yeah.
and getting a diagnosis is just, really, really, really hard. And now, I mean, Hopkins has this huge POTS clinic, like, it's just so much easier now to get that confirmed, but again, this is why I wanted to have this conversation because I feel like it's fully in our wheelhouse of those of us that work in this um, kind of chronic area where we get all the things and it's
Mhm.
all weird and odd and complex and but they all kind of stir around in the same pot and we know more than we think we know, but we have to acknowledge that, you know, we might be seeing more of it because of this kind of relationship to COVID infections and things like that. And we have to just be aware that there's a new, not new, but we just there's going to be more of it, I
Yeah,
suppose.
that's a good point.
Um, so, is there hope where you sit right now in the research chair as a somebody who's teaching, budding physical therapists and you have the academic look on this and you're reading all the things like should we be hopeful?
Um, well, I've been doing this particular work for 15 years,
Yeah.
been in higher ed for over 20. If there wasn't hope, then I'd have a pretty bleak life. Probably would have found
Okay,
something
that's
to
good.
do
We
a
don't
long
want you to
time
have a
ago.
bleak life.
Um, there are things that give me specific hope related to ME and ME related to long COVID and so forth. And that's first that we're having this conversation. When I first started 15 years ago, there was just no conversations.
Yeah.
And being able to be on your podcast today, boring your listeners with this information is a privilege and I think an important step in improving the PR campaign of
Yeah.
ME and ME-like diseases. And so thank you for reserving this time for it. I think the other thing that gives me hope is the data coming out from on the kind of the pathophysiological side regarding some of the underpinnings of ME and ME-like conditions. Um, I think that will ultimately yield fruit in terms of curative treatments.
Mhm.
Um, kind of much more than what we've played with in terms of cognitive behavioral therapy, trying to talk people out of feeling sick, which has not worked.
Right.
Trying to exercise them, which we know from our work and others is not good for people. And so trying to move towards pharmacological and non-pharmacological treatments that can actually influence what's happening in the body.
Yeah.
That gives me hope. Um, Mr. Rogers said, "Look for the helpers." Your listeners who want to do better, give me hope.
Yeah.
Our students who I have the privilege of teaching this information, give me hope. Practicing clinicians that I have a chance to run into at conferences that I discuss this, or the continuing education courses or lectures that they invite me to do regarding this. They all give me hope
Yep.
that we can do better. So there's lots of, yeah, and I'll say too that, and I don't know if it's hope, but it's certainly a source of motivation
Yeah.
for patients when they tell you that they need help, and
Mhm.
they're open about their lives and what's happening to them, and their suffering. Being open about your suffering is always really hard and very vulnerable. So
Yeah.
I don't think hope is the word, but motivation is definitely the word. That there are sick people
Yeah.
out there for reasons we don't fully understand and fully can't help, but we need to do better.
Yeah. It's interesting this morning, totally randomly on one of the Facebook random PT Facebook groups that I'm on, somebody had posted a question and I'm going to read it verbatim here. It says, when it comes to the chronic fatigue syndromes of long COVID, what do you all think about using mild to moderate aerobic training to treat those symptoms? And I read down through the answers and there was more speaking to pacing as opposed to just like, hey, exercise fixes everything. And I was really encouraged, one, that somebody asked the question,
Mhm.
two, that there were answers that had weight and were on the right track. And so that encourages me. But again, I mean, talk about privilege. Like I have the privilege of having this platform and wanting to use it to disseminate as much information as I can to people who are willing to listen to me. And at pelvic PTs, anybody that's working in chronic pain, period, I think you have a unique understanding and awareness and um, just ability to listen and find those nuances and the patience to let someone finish their story. And we're going to hear more stories. And if anybody is going to start this tidal wave that needs to happen in our profession as rehabilitation specialists, it's probably going to be us, because that's our super skill set. And so I'm hoping that if we can kind of be like, oh, hey, this is not new, by the way. We've been dealing with this for a really long time. And obviously you doing research in this for, 15 years. This is not new to you either, but this is a new application. Can we carry these threads through? Can we take what we know? Can we learn from what this new stuff is? And can we get people help sooner so they're not waiting that 7 or 8 years? That's what I'm hoping to kind of do by just having this conversation. So I appreciate you coming on an Active Mom podcast, because really what says chronic fatigue more than Active Mom?
This is true. Absolutely. Well,
Right?
thank you for having me and thank you to your audience. I really do appreciate everyone's time and attention. And certainly, we'll put my social media handle up and we'll put my contact information in the show notes.
Yeah.
If people have questions, I'd be totally happy to chat with you.
I appreciate that. And I will tell you, because I posted up on Instagram, you got to come over. It's a little bit nicer than Twitter, although there's better research posted on Twitter or X or whatever we're calling it this week. I get more papers off of there. But I did have a bunch of your former students, and I should have had them just give me their name. I asked them for any inside jokes or information that might have thrown you off. They were not able to tell me anything in the appropriate amount of time. So sorry about that. But everyone just like that responded, oh my gosh, Dr. Davenport, he's amazing. Da, da, da. So
That's awesome.
you have some alumni that still appreciate you and think fondly of their time with you. So
they're very
it says a lot about an educator that years later you still mean something to them. So clearly you're doing something right. So anyway,
Thank you.
thanks for chatting with us. If you guys want to learn a little bit more about this stuff, Todd's over on Twitter. I can connect you other ways. If you don't want to go on X, that's totally fine too.
Totally understandable.
You're also going to learn baseball stats because you're totally into baseball too, right? Occasionally you throw some weirdo things and I'm like, I don't know what you're watching.
My poor San Francisco Giants are having an awful year and I'm just tweeting through it. So I apologize for some of those.
Yeah, well, DC, the Commanders are finally winning. I know that's not baseball, but we'll take anything here in DC. We've had a drought
It'll
for
be
a
football
while.
season soon, so I'll be tweeting through the 49er season, I'm sure.
All right. So if you want 49ers commentary, check him out there too. Todd Davenport, thanks so much for being on the show.
I appreciate you and your listeners. Thank you.
Did you enjoy the podcast? If so, leave us a 5-star review on iTunes and tell a friend to do the same. Are you a postpartum mom or postpartum pro wanting to know more about getting back to running after baby? Check out all my free goodies on carriepagliano.com. This podcast represents the opinions of Dr. Carrie Pagliano and her guests to the show. The content should not be taken as medical advice and is for entertainment purposes only. Always consult your healthcare professional for any medical questions.